scanning from the side, alright, check for the red reflex, and normally I would see a kind of reddish orange background when I check for the red reflex. Next thing I want to do on the fundoscopy is to make sure I'm holding the ophthalmoscope the right way. So basically, if I'm looking to the right eye, I'll be holding my ophthalmoscope with the right hand. And if I'm looking to the left eye, I'll be holding the ophthalmoscope with the left hand as well. Alright? What I'll be looking for in the ophthalmoscopy examination is that I'll be looking at the optic disc to check if there's any disc swelling, as you can get in glaucoma, alright, where you can appreciate the margins of the optic disc. It all look blurry. Alright? I would also be checking for the integrity of the retinal vessels, like the retinal arteries and retinal vein. Looking for things like ruptured retinal vessels, which can lead to duct or flame hemorrhage. I would also be looking for microaneurysm, which is swelling, some outpouch swelling of these retinal blood vessels. Alright, as you can see in diabetic retinopathy, and that differentiated from other kind of retinopathy like hypertensive retinopathy. I would also want to be looking for exudate, soft exudate, also known as cottonwool spots, and that represents dead necrotic nerve fibers. I'm looking for hard exudates, which represent leakage of lipids from a ruptured blood vessel. Alright? And I also want to be looking for swelling of the macula, some macular swelling as well. I'm checking for other things like even cataracts. Right? But if there was cataracts, then there will be an obliteration or obstruction or absent red reflex. Cataracts. If I saw a white reflex, that may be found in things like retinoblastoma. Alright? Alright, so moving on anyways, I'm skipping the fundoscopy in this case. So moving on to the next examination. A recap, we've done cranial F1, we've done 2, 3, 4, 6. So we'll move on to cranial F5. So for cranial F5, trigeminal nerve, it has branches, mostly sensory but also has some motor branch. For the sensory branch, we have the V1, V2, V3. The V1 is ophthalmic, V2 is maxillary, and V3 is mandibular. So to check for this sensation, I will explain to the patient, this is a cotton wool, and this is how it feels. Can you feel that? Now we're putting this around your face, alright? Just let me know if you feel it and if it feels the same. So I'll check for V1, the ophthalmic, you feel that? Yeah. On both sides, feel that? Feels the same? And repeat that for maxillary, V2, and that, sorry, maybe a bit thickly. And then V3 mandibular, yes? Right, so V1, V2, V3 appears to be intact, alright? The patient can appreciate the sensation on both sides of the face. Now I want to check for the motor component of trigeminal. Remember, it supplies muscle mastication. Alright, so just move your jaw to left and right. Alright, so don't let me push it back. Alright, the other way. Don't let me push it back. I'm sure I'll put your mouth. Don't let me close it. Alright, that's good. Okay, that's fine. And then clench your teeth for me. I'm just going to feel around the temporalis. And that's fine as well. Thank you. Alright, so cranial F5 trigeminal appears to be intact. Alright, I'm going to move on to facial nerve, which is cranial F7. So just smile for me. Show me your teeth and smile for me. Alright, then frown for me. Give me a good frown. Alright, now keep your head still and look to the roof as high as you can. Alright, I can see some wrinkles up there. Thank you. If patient has a cranial F7 palsy, but the wrinkles are intact, alright, that suggests an upper motor neuron type of cranial nerve palsy. The absence of wrinkles would suggest a lower motor nerve neuron type of cranial nerve palsy. Alright. The reason why you have wrinkles is because of the bilateral innervation of the nerve fibers in the forehead. Okay? So now, still on the cranial nerve 7, I would just like to check for the nerve to stapedius, which is a branch of cranial nerve 7. So I'm just going to come close to the patient. I'm just going to close the ears here. Right? Do you hear that? Alright? Do you hear that? Is it loud? It's normal. If it was loud, then that can suggest hyperacusis because of damage to the nerve to the stapedius. Alright? Because if there's damage to the nerve to the stapedius, then the stapedius would not oscillate normally, and the dampening effect on sound wave will be lost, so the sound will be loud. Alright? But there's no hyperacusis here. Next, I want to check another branch of cranial 7, which is caudate tympani. That supplies the anterior two-thirds of the tongue. Have you noticed any change in your sense of taste? No? So no loss. Patient admits normal taste sensation is intact. So that's we done cranial nerve 7. Moving on to cranial nerve 8, the vestibulocochlear nerve. Vestibulocochlear nerve is for balance, the vestibular part, and hearing, the cochlear part. So I would like to first do a quick screening test. I'm just going to open up your ears, right? You can hear that? And you can hear that? If there was any suspected hearing loss, I want to do a specialized test, which is the Weber's test, to check for conductive hearing loss, or the Ryan's test, to check for sensorineural hearing loss. But to demonstrate that, again, we'll pretend this is a vibrating fork, alright? And I will hit the vibrating fork to get it vibrating. And I'm going to come to the patient's ear and ask them, can you hear this? And she'll say yes. Alright, so that's so she can hear the vibration right now while it's placed close to the ear and conducted by air. Then I'll place the fork behind the ear on the master process. Can you hear this now? You see hear this? And then tell me when you don't hear it anymore. Now she doesn't hear it anymore. And then I bring it back here. Do you still hear it? And she hears it. So this suggests that air conduction is greater than warm conduction. Alright? And that's the Ryan's test demonstrated. To demonstrate the Weber's test, same tuning fork, I will hit it here and place it in the forehead.